Hello dear students, welcome to Dr. S. Blank Medicine classes. In today's lecture, let us try to learn about the drugs which are used in the gout. So in this lecture, we will see in detail about the pharmacology of anti-gout drugs. So before learning about the pharmacology of drugs, let us first learn some basic concepts about the gout. So the first one, so what is gout? So we'll discuss the introduction of gout, and then we will see what is hyperuricemia, and the next we will discuss the physiology of uric acid production, or the uric acid physiology, and finally we'll see the classification of anti-gout drugs or the drugs used in the gouty arthritis. So classification of drugs, and finally we'll see the pharmacology. So pharmacology of different drugs used in the gout. So first listen guys, so what is gout or what is gouty arthritis? Commonly we use the term gouty arthritis because usually the joints were most affected, because of that we call it as gouty arthritis. And listen guys, so there is a condition called hyperuricemia. So hyperuricemia is very important term you should understand before learning about the gouty arthritis. Hyperuricemia is nothing but the concentration of uric acid, the elevated concentration of uric acid in the serum is called hyperuricemia, and the general normal range of uric acid is 1 to 4 mg per dl, and if the uric acid levels, if it increases above 4, then that condition is called hyperuricemia. So in hyperuricemia usually, actually the uric acid which is synthesized should be excreted from urine. Okay, so when we have many different reasons where patient will have increased uric acid, so the uric acid which is synthesized in the body, in hyperuricemic conditions, the uric acid is insoluble in water and it will not excrete from the body, and by that it increases the uric acid levels in the blood, and it starts forming urate crystals. So it is also called uric acid crystals, and the uric acid crystals tries to accumulate in kidneys and it forms kidney stones, and some of the uric acid crystals will start accumulating in the subcutaneous tissue, and sometimes these uric acid crystals will accumulate especially in the joints, and by accumulation of these uric acid crystals in the joints, it causes severe arthritis, and that condition is called gouty arthritis. So gouty arthritis is nothing but it is characterized by hyperuricemia, and in hyperuricemic situations the urate crystals accumulates in the joints, and the accumulation of urate crystals has severe inflammation of the joints, and by that it causes severe arthritis, and that condition is called gouty arthritis. And remember guys, gouty arthritis is very different when compared with rheumatoid arthritis and osteoarthritis. So this is very different. Those arthritis will have different cause, and in gout uric acid is the main cause. So, okay, uric acid is very important in gout. So let us see the physiology to understand what actually causes gouty arthritis. So we have different causes of uric acid, and in that we have primary cause. Actually in the primary gouty arthritis, the uric acid production is very high. That may be due to hereditary disorders. Anyways, we will not discuss in detail. So that is the primary cause. And in secondary causes of hyperuricemia, we have many different causes. We have some disease conditions like CKD. So in CKD, because of reduced GFR, the synthesized uric acid will not excrete from the body, and it causes hyperuricemia. And we have leukemia, Leukemia is another disease condition where uric acid production is very high, and in that situations patient will have hyperuricemia. We have lymphoma, and we have polycythemia. Polycythemia is a situation where increased RBC is present in the body, and these are some of the disease conditions. And in most of the cancerous conditions who are receiving radiation therapy, so in radiation therapy millions of cells will be dying every day, and the dead cells will undergo metabolism, and by the metabolism of the dead cells uric acid production is very high. So even in radiation therapy and in chemotherapy patient will have hyperuricemia. So these are some different situations where we can suspect hyperuricemia. And in the secondary cause we also have some drugs. We have some drugs that causes hyperuricemia. We have to listen carefully. So drug induced hyperuricemia is very important. So let me enlist the drugs here. The first one, actually in the drugs we have furosemide, thiazide diuretics, we have thiazide diuretics, and we have ethacrenic acid. Ethacrenic acid is one of the loop diuretic, and even this drug causes reduced excretion of uric acid from the kidneys, and it causes hyperuricemia. And we have levodopa. Levodopa is another drug that causes hyperuricemia. And we also have some antitubercular drugs. So we have ethambutol, pyrazinamide, and there is a drug which is used for obesity. It's called clofibrate. So these are some of the drugs that causes hyperuricemia, and till now we know these drugs which induces hyperuricemia. So these are commonly common drugs which are used in the hospitals that causes hyperuricemia. So these are the different secondary causes of hyperuricemia. So now let us see the basic concept, how uric acid is synthesized in the body. So now let us discuss the biosynthesis of uric acid actually. So listen guys, most of these cells after death in our body, so the dead cells will undergo metabolism. Actually proteins will form urea, and the urea is excreted from the urine, and the fats will undergo fatty acids, and further it is used in the formation of ATP, and few amino acids are also metabolized. But we have nucleic acids also. So nucleic acids are the basic components of nucleus, DNA and RNA, and in this nucleic acid we have purines. So purines will have adenine and guanine. So adenine and guanine are the main constituents of purines. So this adenine will undergo different metabolic reactions, and finally this adenine is converted into hypoxanthine, and this guanine is converted into xanthine, and this hypoxanthine again it is converted into xanthine, and finally the xanthine is converted into uric acid. Remember guys, this is the general biosynthesis of uric acid in our body. So purines are the major precursors which helps in the production of uric acid, and here hypoxanthine is converted into xanthine by a very important enzyme called xanthine oxidase. So xanthine oxidase converts hypoxanthine to xanthine and xanthine to uric acid. Again here also xanthine oxidase enzyme is very important. And listen guys, uric acid after production, the small amount of uric acid will be excreted from urine, but when uric acid production is high, in higher amount of uric acid production, this uric acid tries to accumulate in the tissues, as we have discussed in the earlier in the introduction. So uric acid is non-soluble in water actually, and that accumulates in the kidneys and forms kidney stones, and it accumulates in the subcutaneous tissue as well as in the joints. And when the uric acid accumulates in the joint, it causes severe inflammation, and it is the main reason for gouty arthritis. Okay, and listen guys, Actually, these gouty arthritis and gout related diseases are not seen in other mammals, and this gout is commonly seen in human beings. Other than human beings, gout is not seen in any mammal. Why? Because the uric acid, after the synthesis of uric acid, this uric acid is again converted into some water soluble form called we have a substance called so the uric acid is again converted into water soluble substance called allantoin in the mammals actually. So this uric acid is converted into allantoin by a very important enzyme called uricase. So uricase enzyme is absent in human beings. So that is the reason uric acid accumulates in the body and it causes some lethal effects. So this is very important. The uricase enzyme is present in the mammals, and the uric acid is again converted into allantoin, which is a water soluble, and so that is the reason mammals will not have such lethal related diseases. Okay, so this is the general biosynthesis of uric acid. I think we have discussed some basic concepts. So I think you learnt about the definition of gout. So now we can say that gouty arthritis or gout, it is a metabolic disorder of purine metabolism. Okay, actually it is a purine catabolism. So it is a metabolic disease with excess catabolism of purines. So that leads to gouty arthritis. So we have some see, gout may be possible due to two different reasons. The first one, gout may be seen with increased production of uric acid, the first thing, hyperuricemia, and due to the reduced excretion of uric acid from the body. So these are the two different situations where we can observe hyperuricemia in the patient. So now let us discuss some the drugs which are used in the hyperuricemia. So listen guys, we have two main different categories of drugs which is used in the gout. So the first category or the first class of drugs comes under acute gout. So drugs for acute gout, and for acute gout we have NSAIDs, we have corticosteroids, and the next one is very important, colchicine. So colchicine. So these three different drugs are used in the acute gout related diseases. Okay, so here in this class we will discuss about colchicine. Anyways, I will not discuss about NSAIDs and corticosteroids. I have already discussed about NSAIDs and corticosteroids. I will provide the description in the link. I will provide the link in the description. Okay, and the second class of drugs which are used in the gout are synthesis inhibitors, or the drugs which reduces the biosynthesis of uric acid, and in that we have allopurinol. So allopurinol is the drug which reduces the biosynthesis of uric acid, and by that it reduces the production of uric acid. And the last category of drugs is uricosurics. So uricosurics, in uricosurics we have febuxostat, we have probenecid, and yeah, so these are the drugs which are the commonly used drugs for the gout. So now we will discuss about each and every drug profile. So we'll see the detailed pharmacology of the drugs which are used in the gouty arthritis. And now let us discuss about colchicine. So colchicine is very important drug which is used in the gouty arthritis, and it is used in the acute gout symptoms. So okay, so colchicine. The colchicine, it is not an analgesic and it is not anti-inflammatory drug. It is not having any of the properties, and even then it is used in the gout related symptoms. Okay, so colchicine is very important drug, and the colchicine, remember guys, it is a alkaloid actually. So it is synthesized from the plant, and this alkaloid is synthesized from Colchicum autumnale. So Colchicum autumnale is the plant, and from this plant the colchicine is synthesized. And remember guys, we should understand the mechanism of colchicine. Colchicine mechanism is very, very important. Just zoom it here. So see, actually in the gouty arthritis, the inflammation is commonly seen because the urate crystals are accumulated in the joints, and by that it causes severe inflammation. See, when uric acid is accumulated in the joint, by that first granulocyte will be activated. By the accumulation of uric acid crystals, activation of granulocyte occurs, and by the activation of granulocytes, the urate crystal phagocytosis occurs. The phagocytosis of urate crystals occurs, and by the phagocytosis, some glycoprotein will be released into the joint. So the glycoprotein release is very important. So by the release of glycoprotein in the joint, so by the release of that, some lysosomal enzymes are also released into the joint, and by the release of lysosomal enzymes, these enzymes will try to degrade the joint, and by that degradation of the joint, severe inflammation occurs and severe pain occurs. And by the release of glycoproteins, here the pH of the joint is also reduced by the lactic acid production, and the lactic acid production reduces the pH, and by that it precipitates the urate crystals. So in the reduced pH, actually in the acidic pH, the uric acid again precipitates in the joint, and by that severe inflammation occurs and the problem again exacerbates. So this is the general physiology of pain and inflammation in the joints. But colchicine is a drug. It tries to inhibit, or it tries to stop the release of glycoprotein. So colchicine stops the release of glycoprotein, and by that it stops the release of lysosomal enzymes, and it also stops the reduces the lactic acid production, and by that it stops the inflammation of the patient. So this is the general mechanism of colchicine. So mechanism of colchicine is very important. Okay, so that is the mechanism. And the kinetics. See, colchicine is actually it is a alkaloid, and it is very much absorbed through GI tract, commonly given through GI tract, and it is very much absorbed, and it undergoes metabolism in the liver actually, and after metabolism it undergoes enterohepatic circulation. This is very important. So colchicine undergoes enterohepatic circulation, and 25% of the colchicine is excreted through feces, and mostly 70 to 80% will be excreted through urine. That is the kinetics. And we have many adverse drug reactions for colchicine. Remember guys, colchicine will have severe gastric irritation, and most of the time it causes severe diarrhea. Nausea, diarrhea is very common with colchicine, and sometimes even bleeding, hemorrhagic bleeding occurs. Gastric hemorrhage is commonly seen with colchicine. Rashes, hypersensitivity is very common, and sometimes alopecia, hair loss occurs with colchicine. Okay, so these are the common ADRs with colchicine, and this is very important, you have to remember. And the dose. Colchicine commonly, first we will start with 1 mg of dose. 1 mg should be started, and after giving 1 mg of colchicine, for every 2 hours we have to give 0.25 mg of colchicine for every 2 hours, because its duration of action is very low when compared with others. Its duration of action is very low, so for every 2 hours 0.25 mg is given continuously till the diarrhea is seen. So diarrhea is very, very commonly seen adverse drug reaction with colchicine. So till diarrhea occurs, we have to give 0.25 mg continuously to the patient. So this is about colchicine. So now let us see about the other drug. Actually this colchicine is given in the acute gout, and for chronic gout we have 2 major drugs. One is uricosuric and one is xanthine oxidase inhibitor. So we have allopurinol. So now let us discuss about allopurinol. So allopurinol is very important drug in the hyperuricemia. So commonly 100 to 600 mg is the common dose of allopurinol, and let us see the mechanism of action of allopurinol. Remember guys, allopurinol is a xanthine oxidase inhibitor. So xanthine oxidase is very important enzyme, as we have earlier discussed. See, we have guanine and adenine. Actually adenine is converted into hypoxanthine, and hypoxanthine is converted into xanthine by an enzyme called xanthine oxidase, and the xanthine is converted into uric acid by xanthine oxidase. So here this allopurinol will inhibit xanthine oxidase in these two steps, and by inhibition of this enzyme it stops the production of uric acid. So actually this is the rate limiting step of uric acid production. So allopurinol is a xanthine oxidase inhibitor, and it reduces the biosynthesis of uric acid in the body. So this is the mechanism, and allopurinol is commonly given in chronic gouty arthritis, and it has many drug interactions. So we have to concentrate on drug interactions. So allopurinol interacts with warfarin and theophylline. Warfarin and theophylline metabolism will be stopped, or it reduces the metabolism, and allopurinol increases their serum levels, and by that it increases their toxicity. So this is one interaction, is very important interaction. And allopurinol is having severe hypersensitivity, and when allopurinol is given with penicillins, it will have severe anaphylaxis. So okay, that is very important, another drug interaction of allopurinol. And now let us see the kinetics of allopurinol. Allopurinol is commonly given in oral route actually. So oral bioavailability is 80 to 90%, and most of the allopurinol is not bound to the proteins, and it is metabolized in the liver. Remember guys, it inhibits its own metabolism. So allopurinol inhibits its own metabolism most of the time, and actually the allopurinol is metabolized into allopurinol is metabolized into alloxanthine. So actually allopurinol is having the major activity, and even alloxanthine, the metabolic product, will also have severe xanthine oxidase inhibitor property. So even this metabolism is having property. Actually allopurinol will bind this enzyme reversibly, whereas alloxanthine will it binds to this enzyme irreversibly. It binds reversibly and it binds irreversibly, and this alloxanthine will have severe activity when compared with allopurinol. So this will have severe efficacy when compared with allopurinol, and most of the allopurinol is excreted as alloxanthine, and 1/3 of allopurinol is excreted unchanged through urine. So this is the kinetics of allopurinol. And while talking about kinetics, remember guys, allopurinol metabolizes its own, it stops metabolism of its own drug, and it is metabolized into alloxanthine, and alloxanthine will have high property of binding to xanthine oxidase enzyme, and by that it stops the production of uric acid. So two actions. So metabolic end product also will have its action, and allopurinol is one third of the allopurinol is excreted, and remaining all the metabolized end product will be excreted from urine. So this is the kinetics of allopurinol. And so allopurinol is also having another very important interaction. Actually 6-mercaptopurine and so 6-mercaptopurine and azathioprine. So these are the two drugs. So allopurinol will inhibit the metabolism of 6-mercaptopurine and azathioprine. So this is another very important drug interaction with allopurinol. So I think these are the different pharmacological So let us discuss about uricosurics. So in uricosurics we have probenicid, we have febuxostat, and we have adjunct drugs. So we have another sulfenpyrazone. So these are the three drugs in uricosurics, and we will discuss in detail about probenicid. So probenicid will resemble the other drugs also. So listen guys, actually probenicid stops the excretion of uric acid from the kidneys. Actually, see, listen guys, so this is glomerulus and this is efferent arteriole and afferent arteriole. Actually the blood comes through here and here it is filtered, and this is PCT, proximal coronary tubule. The uric acid which is coming from the efferent arteriole, it undergoes glomerular filtration. So 90% of the uric acid undergoes glomerular filtration and it is present in the tubules, and the uric acid which has undergone glomerular filtration, it will be reabsorbed back into the blood. So most of the uric acid is reabsorbed into the blood. So because of that, it will have hyperuricemia. This is very important point. And the 10% of uric acid which is present in the efferent arteriole, again it will undergo tubular secretion. Okay, so this is the general physiology of uric acid. And listen guys, when febuxostat or when probenicid is given, probenicid will competitively block the reabsorption of uric acid into the blood, and it also blocks the reabsorption, the tubular secretion of uric acid here. So it stops the reabsorption of uric acid in the blood, and by that it increases the uric acid level in the urine, and by that it increases the excretion of uric acid. So probenicid competitively blocks the reabsorption and tubular secretion of uric acid. So this is the major mechanism of probenicid. And remember guys, by this mechanism you have to understand some other drugs. So most of the drugs, some anionic and cationic drugs, are excreted through the kidneys by tubular secretion, and in that we have penicillin, very important drug, penicillin, cephalosporins, we have salicylates, and we have gluconoride conjugates. So gluconoride conjugates, and so these are some of the drugs which will not actually undergo glomerular filtration. They are excreted in the urine by tubular secretion, and these drugs are competitively blocked the secretion of the tubular secretion into the proximal coronary tubule, and by this probenicid increases the levels of these drugs. So, okay, this is very important. Penicillin, cephalosporins, and some of the salicylates and gluconorides, their plasma level concentration increases when probenicid is given in combination with these drugs, because it blocks the tubular secretion of these drugs. So usually when penicillin and cephalosporin, along with penicillins and cephalosporins, we can give probenicid because they will have increased efficacy of penicillins and cephalosporins. But there is also another drug called nitrofurantoin. Nitrofurantoin is very important drug. Even these will undergo tubular secretion. But with nitrofurantoin, we should strictly contraindicate probenicid, because nitrofurantoin secretion will be stopped by probenicid. Actually, nitrofurantoin should secrete into the tubules, and in the tubules it will have its activity, because nitrofurantoin is a urinary antiseptic. In urinary tract infections, it is drug of choice. So probenicid should not be given along with nitrofurantoin. because it is a bad effect, whereas penicillins and cephalosporins, it can be given because it increases their levels, and by that so this is about the mechanism of probenecid. And now let us see the kinetics of probenecid. Probenecid is very good absorbed from GI tract. So usually we have 250 mg tablets, 250 to 1 gram can be given per day. So this is general dose of the probenecid, and most of the probenecid is absorbed from GI tract, metabolized in the liver and excreted through kidneys, okay, especially by tubular secretion. And yeah, this is the kinetics of probenecid. And drug interactions, anyways, we have seen it interacts with nitrofurantoin, penicillin, cephalosporins, salicylates and gluconorides. So in that situations, drug interaction is seen. And yeah, it is commonly used for chronic gouty arthritis. So this is about probenecid. And listen guys, if I miss something in this video, and if you learn something in this video, please don't forget to subscribe. And if I miss something, please comment and ask, or you can note me below in the comment. And don't forget to share this video with your friends. Someone somewhere will find it useful. And thank you for watching.